Hello and welcome back, everyone. Looking forward to getting into the topic for this week, which is going to be psychopathology. We're going to be following up on some concepts from previous classes like the social self, group identity, identification, where we might compare, who we really are to an ideal, have certain feelings about that. Last week we had talked about, or a few weeks ago we had talked about, Bem's theory and how we look at the world around us to try to get an idea about, who we are. If we start to think about this a little bit more, we can see how this might create good situations or maybe bad situations for people, where if someone grows up in a particular situation that mainly reflects negative information about the self, could we imagine that this is going to lead to further problems down the line? Developmental psychologists like Erik Erikson talked about this idea of arrested development, which says that as someone is growing and developing, they face certain challenges in life. Really, this is, a process of social development, social maturing. However, if someone maybe struggles to form the very basic aspects of, a social self or a group identity or, a stable self-concept, a stable attachment concept, then we might start to see like a build-up, an accumulation of suffering. And in many cases, it's very tough to identify what the suffering is about or where it comes from. What does it actually go back to? And so for this reason, we're going to start to touch a little bit on, psychotherapy, the applied branch of psychology, the way that the field tries to use research or, rigorous theory as much as possible to explain sort of these snags that happen in human development, sort of what goes wrong, or if we want to make things go right, how do we go about and do that? So we are going to be explaining or exploring this idea of a mental disorder. So I'll start by pointing out that a mental illness, it is something that you could call a social construct, but it's also a scientific construct. So we don't exactly know what the problem is, and with any mental illness, we run two main risks. One, we're using a disease metaphor to apply, a physical understanding of dysfunction to sort of a mental, spiritual state of dysfunction, which is okay. A metaphor is often the best that we could do to try to explain something difficult, but I want to acknowledge right off the bat, that there's some simplification happening. The Diagnostic and Statistical Manual, the DSM, many of you might have heard of, is, a book that has been published by the American Medical Association as a way of, observing mental and social abnormalities as they present themselves in the individual. Now, there is a risk right off the bat that just because someone seems maybe weird or even from another culture, that we're just going to label them as having a disorder, when actually we're just looking at someone or a set of behaviors that maybe are operating in a context that is unfamiliar. And so in that way we might be dealing with more regular human emotions, such as, loneliness or frustration. So somewhere, waiting up in the wings, there's a hope that people could, self-actualize especially when it comes to psychotherapy as a professional project. And so in that way, we might want to actually help people, give them a sense of what is going on, so then as they recognize their self and their own internal processes more, as they get more perspective on their social identity, that they can start to take charge of these things, because they will be able to see accurately what is happening. And that ultimately they will be able to take a next step that is maybe something like the best possible step. If anyone ever gets a chance to go to the MFA, you can see this interesting artifact that I have up on slide number 2. It is titled a Humbaba charm. Humbaba is the name of a demon, or maybe some sort of a elemental wizard from the ancient Mesopotamian story Gilgamesh. And this might give us a bit of a snapshot into how mental disorders or mental illness or insanity or a fixation was understood, felt, illustrated by other people who are not part of the APA or the American Medical Association, or, you know, were understanding people long before the DSM came around. I say this by way of, I guess, memory of culture, you know, wanting to not, excuse the, you know, crude way of saying this, but not dumb ourselves down and sort of pretend that all of these more complex things that humans think and feel and portray and strive for can just be, you know, chalked up and reduced to what we could put in the pages of the DSM-5. And hopefully then that will allow us to really see just how useful and also how limited a scientific study of mental illness is, as best as we can do so far. You know, there was a push made by the Department of Mental Health back when I was in grad school to only fund studies that showed a genetic marker for a mental illness. And the goal of this was to sort of stop inflating these concepts of disorders that on some level are not real. Unfortunately, that push didn't really pan out just because it proved too difficult to do psychological research at all at that point. And yet there is a sense that, you know, professionals have to do something, because if it was left to people who, one, aren't professionals, you know, don't have the training to be able to observe and sit with extreme states of mental distress, that, you know, there's always a question of just sort of delving back into traditionalist viewpoints, traditional sources of authority or knowledge or custom. And so this is really what separates, you know, scientific inquiry from tradition or conservatism even. So, you know, there is a sense that a lot is at stake when it comes to mental health, and the fact that suicide rates tend to be, you know, we could really look at a lot here when it comes to looking at, you know, societies that experience war, or chronic famine, or, you know, just sort of wide-scale tragedy. But, you know, generally research tends to show that it's the developed nations that have higher rates of suicide or mental health. So, you know, there's something interesting about that there's like a subtlety to mental disorder, or, you know, you could sort of take a camping trip for a weekend and just feel like you've got a whole different viewpoint on your problems. and that may stick around. You might find a way to sort of help those adaptive beliefs or perspectives stick around. But on the other hand, it might kind of creep back in and through little nooks and crannies of your life, and by that I mean a modern life. So it may be helpful to, think of this idea of kind of this Humbaba demon charm to maybe show something that's a universal portrayal of mental or psychic or spiritual abnormality. And, as the individual, as we see here, reflected in the individual face of this Humbaba charm, that as someone starts to drift from recognizable, universal experiences, meaning you're maybe, let's just say, starting to get into your own head, other people can't relate to you, very common phenomena, that there may be something excruciating and intense about that. So let's get a little bit more concrete, talk a bit more about the DSM. In the DSM-5, it was not always this way. The DSM-3 was the first guide, first DSM guide to really look at mental disorders in a way that primarily focused on behavior or observable phenomena, or self-report at least. And there was an emphasis to decrease the use of theory. And so that meant, primarily psychoanalytic theory, psychodynamic theories were not used as much as of the DSM-3. Of course, the goal for this was to move more toward science and away from philosophy. And, I think there is a noble aspect, a noble goal to that, where practitioners are sort of trying to get away from the ridiculous chauvinistic notions of, let's just say, the learned class of, the 1800s. Which isn't to say that they didn't know more than practitioners today in some respects. But, when we get into Freud and the psychoanalytic model, and, the phenomena of hysteria and sort of the way that this would simplify and sweep away the negative effects that society was having on women, or the way that, sexual desire, we could just say sexual frustration in female patients was viewed kind of as just like a nervous disorder by doctors, right? The sense that there might be something normal, something more reasonable that's very easily at hand was just not really considered as much back then because, society and all of its knowledge was just prized so highly and taken for granted so much. So there is something good, certainly, about the DSM moving towards, a more face value, more observable, more behavioral view. And so now we classify disorders in terms of mood disorders like major depressive disorder or bipolar disorder, anxiety disorders like OCD. PTSD is also considered an anxiety disorder. And then we also have psychotic disorders, which includes schizophrenia or schizoaffective disorder. In order for diagnosis to be made, this is an important point here, the individual must display significant impairment and distress for a specified period of time. Let's just say, minimum of 2 weeks in the case of major depressive disorder. What this does is the requirement tries to avoid stigmatizing, making a problem of relatively normal behavior. Another important piece to that is that there has to be impairment, right? Not just distress. That it's going to be hard to do what you want to do. It's going to be hard to fit into with society. And so I say that to say, that society is what we have to adapt to. those of us who live in it. And that should mean that we have a concrete reminder of what's practical here, which is that people have to face the jobs and the situations that they do. They're not living in some ideal land. And then on the other hand, just how dependent a lot of mental illnesses are on context. So let's define, this is going to be helpful, some of these words here. Psychopathology, the scientific study of mental illness. And, in some ways that may even be a paradox. How do you scientifically study something you can't see? In the case of disorders like PTSD, certainly we can see biological markers of, certain risk factors for, heart disease, or, even down to things like acid reflux disorder. We do see, or muscle tension, we do see certain things happen physically on the physiological level with these disorders, or right with bipolar disorder, the fact that you can give someone, just to look at an old drug that's still used, lithium, and just the addition of that drug to the human body has a profound influence on the thoughts, feelings, and behavior of people with bipolar disorder. Psychotherapy, that's also going to be a topic for today. This is just what we talk about in pop culture by therapy, But I want to remind you all that, there are some errors being put on with the concept of therapy, and that it commands a certain level of authority within culture, Just the fact that there are how many YouTube videos right now where, a therapist is going to break down, the Will Smith and Jada Pinkett red table and, explain who's saying what and what's healthy and what's not healthy. This is an interesting and very modern thing where this type of viewpoint is seen as being more sober, as being more, less dramatic, and more independent in its judgments than, a lot of traditional authorities, such as, parents or religious organizations, that type of thing. As we continue to look at the slides, I want you to remember this idea of psychopathology in a social context, and so you should definitely check out this Netflix documentary, Bigger, Faster, Stronger. Now, if we turn to page 422 in our text, we're going to talk about depression and empathy. So, although empathy is a very important quality to have for a lot of jobs these days, to be able to imagine how other people are, feeling physically, mentally, and to be able to, share those emotional spaces with someone, whether that's setting a limit even, and, withdrawing in a healthy way from an emotional space, or, trying to figure out what's going on with someone, because sometimes help brought at the right time can make a world of difference, like just the story of someone who's half a day's walk from, a village or society. They're lost in the woods or the jungle, and they're wandering around for 3 days just because they don't have help, they don't know where to go. So to this point of empathy and professional competence, it can be really helpful to be able to analyze feelings, discuss feelings, or temper feelings, and that is an act of compassion, but we have to use those same skills in reverse also, so compassion or empathy doesn't become obsessive and the grounds for kind of a distressing and obscene rumination on human suffering, something that should be addressed but has to be addressed in a systematic way. And that's certainly the view, that psychotherapy takes, a highly systematic approach to social and emotional problems. So, we do have to think of something like rapport, or just sort of normal people talk. That's important, because although there's a benefit of sort of pulling back and taking a bird's eye view of what happens between people, that does start to take on a certain clinical tone, just which might bring about certain limitations or strengths. But it just isn't the same as colloquial speech. And then so therefore it might have a certain incompatibility with, other social practices or social discourses. Depression, anxiety, self-esteem, and discrimination. Okay, so we just talked about how high levels of empathy can be helpful but also be a risk factor for depression. Discrimination, it's being, sort of put into a box, not based on what you say, not even based on what a reasonable person might expect from you or about you, but you're just sort of viewed in a very abstract, highly stereotyped manner. This can feel limiting and dehumanizing to people. The authors of our text cite a large meta-analytic study, which means they are pooling together a lot of previous studies. And this suggested, basically looking at a wide number of studies, that experiences of discrimination, which sort of puts people into statuses and groups and all that, these experiences of discrimination are positively correlated with depression, anxiety, and with low self-esteem. Now, I don't want to simplify this too much because, many studies also find that, white Americans tend to be at a higher risk for certain mental disorders, depression, anxiety, and even, the incidence of suicide. And so why is that? Is it just, lack of study, lack of reporting, lack of access to care? Certainly all those things. But, this also has to do, when it comes to a chronic mood dysregulation, that the way someone sees themselves. So, it might turn out that someone who's from a majority group, socially speaking, is experiencing a really tough time. Maybe they're struggling with suicidal thoughts, or just, depression or panic attacks, and they don't know why they are upset, right? And so this does recall some of what Adorno said in our last lecture about the importance of recognizing stress or aberrant experiences, of recognizing pain, because then many things happen when you can recognize your own pain. But one thing that happens is we can detach that diagnosis from our general sense of self, that, oh, well, it's not just that I'm messed up, but it's just as that, well, this happened and I'm getting over it. So it's a bit of a paradox, you could say, at least looking at superficially, that people from, majority groups are the ones who tend to maybe even have the space to complain about these problems. But, I wouldn't make light of anyone's problems here. It's very dangerous to do that. And that, the phenomena of alienation is very important here, that of feeling like your problems are your own problems and no one else's. And so then, this actually does the opposite of what therapists want to do in treating disorders, which is to sort of communalize that pain. So, it can be talked about, mediated, moved around, and people can maybe even give you help, not to mention make you feel less lonely. To break down some of this stuff, maybe to a more manageable level, using, established theory, there is an idea of depressed thinking. On page 618 to 619 of our text, our authors discuss the ways that depression can be associated with certain thinking styles or certain explanatory styles. The idea that on a subconscious level, they don't exactly use this word subconscious for these modern, we're talking about cognitive behavioral therapy, basically, views of, distress. They don't say exactly, subconscious, but just something that we're primed to think about, right? Quicker, more easily than other people who maybe wouldn't have had a similar difficult background. but just ideas of being, unlovable, of being incompetent, and how that might bring about, as they see in CBT, certain thinking traps, such as, discounting the positive, or black and white thinking, emotional reasoning, catastrophization. In CBT, that's cognitive behavioral therapy, which I'll say a little bit more on, in just a moment. People are taught to develop habits in sort of catching these thoughts so that they can, in a way, let's just say, get back to reality and, make the most of things and pay attention. More about depressed thinking, that individuals are more likely to report depressive symptoms if they attribute failures, bad events to factors that are external and global rather than internal and specific. People are more likely to report depressive symptoms if, the things that are going wrong are something that, everyone deals with, versus if it's just unique to them. So this is a little interesting because, research actually shows that people who live through earthquakes, or, natural disasters where there's no perpetrator, they actually have less psychological distress. We don't want to be too sweeping here because, right, someone could experience something truly horrific in a natural disaster and really experience significant setbacks from that. But, we're saying in general that people tend to do better if the bad event was something that just happened, But if it's something that was done to them, then it sort of activates, sort of these other ways of thinking or feeling, or, experiences of being a victim, experiences of needing to extract revenge somehow. And then with revenge sort of comes other dark emotions, such as guilt or rage or fear of getting caught, any of these things. Summarizing this all, that it's the more private stuff that people are kind of less likely to own up to as being something that's going wrong for them. And so we could certainly think of, social stigma. The idea of depressed thinking, this construct here, comes from cognitive behavioral therapy. On slide 9, you can see this triangle of behavior, thoughts, and feelings, which is a very typical exercise that's done early in cognitive behavioral therapy sessions, is to just start to push human experiences into these different quadrants, to limit it, to reduce it. So you can say, well, I had a panic attack when I got in my car, and then the therapist says, okay, well, what were you thinking before you got in the car? How did you feel after you had that thought? After you felt this way, what did you say to yourself? What did you do then? How did you feel then? And to sort of use these three extreme constructs of thoughts, feeling, and behavior to start to simplify and separate what happens, and that allows clients to develop a sense of cause and effect. And when you start to get a sense of cause and effect for your life, then you can start to make changes to get different effects, we would hope. So CBT is a very well-researched model for, especially depression and anxiety. If you go to your primary care physician and you have something that touches on, psychological or emotional issue, they'll probably tell you to get CBT. This is a slightly out-of-date approach. I mean, CBT is very powerful and it's very simple, and simple meaning applicable, and it strives to be concrete and to assert concepts in a way that is as self-evident as possible, right? It's very sure. Is there a risk of drinking the Kool-Aid with this type of simplification of the human experience? Of course, but therapists also, well, in my opinion, would do well to be able to give their client, some concrete sort of concept skills, something that they can do and work on, that can give a sense of empowerment, or it might even work, it might even allow someone to start to just make a few minor changes, and then everything sometimes does fall into place for people, not always that way, but it does happen. And so, we do have a nice simplicity with cognitive behavioral therapy. with the thoughts, feelings, and behavior distinctions. And so we're teaching the client, we being therapists, teaching the client how to influence that relationship, and make changes. So a couple notes on, follow-ups to CBT. Mindfulness-based behavioral therapy is often seen as being an uptake to CBT, and it brings in, if you might be able to tell this from the word mindfulness, it brings in spiritual approaches, specifically, but not limited to, but chiefly Buddhist and Eastern approaches, to accept and commit the state of affairs in life. And it's seen as, in a way, being less harsh than CBT. This is speaking super broadly. So if there are anyone in this class who has CBT training, don't think I'm bashing CBT. I have CBT training myself, and I find it very helpful. But things do come out in the wash in a certain way. Certain improvements can be made when it comes to these theories. And so it's been posited that mindfulness-based therapies kind of are less critical and are less likely to encourage people to fixate on their flaws. It's less about debating with yourself. It's less about being critiqued or challenged by your therapist. Some people, this is the probably most common stereotype of CBT, and certainly it can be wrong or misguided sometimes, but the stereotype of CBT is that the therapist is going to be harsh and kind of force you to look at yourself clearly and take account of things. Don't be so emotional. Whereas mindfulness-based approaches, there's also acceptance and commitment therapy that's also a mindfulness-based approach, more or less. They're going to say, listen, you feel this way. I mean, what are you going to do about it? You probably can do something about it, but you probably, maybe you can't. Maybe you can't do anything about how you feel. Maybe it doesn't matter how you look at what's going on in your life. Maybe what's going on in your life objectively is really hard. And, they don't just leave someone at that point of stoicism, but they say, okay, so what are your values? What's important to you? How can you start to focus on, what went right over the past week or the weekend? What did you get done that was great, that maybe will give back to you, even if it was painful or stressful or draining? And the idea is that this will help clients be more in touch with what really matters to them and help them tolerate stress more. It's also supposed to help avoid cycles, of self-criticism, which might only further cement anxious and depressed thought patterns. I just have a citation here so you guys can sort of be in the know about this. Yes, it's been increasingly popular to recommend that CBT include aspects of mindfulness-based behavioral therapy. A lot of your, right now anyway, right, 2020, a lot of your primary care doctors still don't know this, unfortunately. But a lot of research, we have this study coming out of BU. It's all the way back from 2011, actually a rather long time ago, but sometimes it takes a long time for this stuff to trickle out outside of, mental health experts, where they're basically saying that CBT greatly benefits from having elements of sort of mindfulness meditation, of acceptance training, of distress tolerance, and values-based work. I'm going to ask that you kind of just pause for a minute. We're about to just switch over to the second part of this lecture. But before you do that, why don't you check out the YouTube video I posted for Leaves on a Stream. This is a classic mindfulness-based exercise. And I think some of you will find it, interesting, maybe helpful. So please check that out and tune back in for part 2 to our lecture.